I want to thank the organizers of ASDIN 2020 for accepting this abstract. Today I'm going to talk about the U.S. Ellipsys Registry, the first post-market experience. Here are my disclosures. So the Ellipsys EndoAVF is made by accessing the cubital vein below the elbow, then advancing the needle through the perforating vein, and then under ultrasound guidance, entering the proximal radial artery. Over this wire, a radial artery sheath is placed using the Terumo 6 slender. We're going to position the Ellipsys catheter between the artery and vein. The jaws will capture the artery and vein and apply pressure up to 200 psi and temperatures of up to 150 C to weld and cut an elliptical anastomosis. Often there's spasm at this point. So the goals of the registry were to commit to ballooning the proximal fistula immediately after creation of the anastomosis, and then at 4 weeks to prepare the fistula for cannulation. We wanted to determine what percentage of patients in a multi-specialty practice would end up having the percutaneous fistula as opposed to having surgery. We wanted to use the best practices from the pivotal trial to see if we could improve the results of that trial. And finally, we want to identify the characteristics in terms of physical exam and Doppler ultrasound examination at the time of two-needle cannulation. Indications for fistulas in this trial were end-stage renal disease 4 or 5 following Kudoki guidelines. Of course, percutaneous fistulas, in addition to the standard surgical vein mapping criteria, require that the proximal radial artery be 2 millimeters in diameter and the perforating vein also be 2 millimeters in diameter and be in close proximity, essentially touching. So here's the flow chart. We evaluated 123 patients. Of those patients, 95 actually have fistulas. Both of the original group, there was 61% that were candidates for percutaneous fistula, and in the group that ultimately had fistulas, 63% of those patients had percutaneous fistulas. Some of those patients were candidates for both surgery and percutaneous fistulas, but had surgery because they had a wrist option. So here's what patients got. So 37% got surgical fistulas, and then 63% got percutaneous fistulas, the majority of which were cephalic. The basilic and brachial fistulas were done in 2 stages with fistula creation followed by transposition. The Ellipsys device is ultrasound guided. It was designed to be used in the office. It creates a tissue-fused anastomosis by grabbing the artery and vein between the jaws that are up in this insert here. The tissue-fused anastomosis is immediate and permanent. You can see up in the top right-hand slide that there is dehydration of the tissue around the edges of the anastomosis. This is also immediately balloon dilatable. We plan to prepare these patients for needle access at 4 weeks, and we did this routinely during the registry. So what were the outcomes related to 5 millimeter balloon angioplasty at the time of anastomosis creation? It had no effect on procedure time or technical success. There were no complications related to use of 5 millimeter balloon in all patients. It did nearly double the brachial artery inflow to 649, where it had been previously 330 in the pivotal trial. It reduced the number of maturation procedures needed to achieve cannulation of the fistula from 2.0 to 0.87, and it markedly reduced early thrombosis to 2% compared to 11%. Patients were prepared for dialysis. The criteria were that they had a palpable fistula in the upper arm, and guidelines for Doppler flow were 500 ml per minute flow in the target vein and 5 millimeter diameter for the target vein. This required 62% angioplasty, deep embolization in 32%, banding of the median basilic vein in 30%, and surgical transposition in 33%. On the right, you see an example of a cephalic fistula where there's been banding of the median basilic vein. The brachial veins are both small and did not require any additional treatment. So event time endpoints include the original physiologic endpoint for the pivotal trial, which was brachial artery flow of 500 ml per minute and target vein diameter of 4 millimeters diameters. We achieved this in this trial in 11 days, so this was not very meaningful as these patients were not ready for dialysis. We've used a new definition of physiologic maturation, which is target vein 500 ml per minute and target vein diameter of 5 millimeters. We achieved that in 40 days. Patients were released for dialysis on an average of 59.6 days. 2-needle cannulation was achieved in 65.6 days in 87% of patients. This is a world-class number, very good. Fistula success, the repeated use of the fistula 2 out of 3 times at the prescribed rate over the period of a month, 79 days to achieve that, and then tunneled catheter removal, 113 days. Fistula characteristics at the time of 2-needle cannulation: brachial artery flow 944, target vein flow 674, target vein diameter 6.1, and target vein depth of 3.6 millimeters. So this goes along with what we saw from Charmaine's talk earlier today, where the depth plays an important factor in limiting cannulation of these fistulas and surgical fistulas as well. When we compare the U.S. registry against the U.S. RDS, the registry is in blue. That's the 65 days to 2-needle cannulation mean. Here in the surgical fistula, it's 135 days mean to 2-needle cannulation. Note that you only achieve that in 62% of surgical patients. An additional 25% of patients achieve 2-needle cannulation in the group achieving or getting a percutaneous fistula. So in conclusion, 63% of patients had percutaneous fistulas from a multi-specialty practice. The use of 5 millimeter balloon angioplasty at the initial fistula creation doubled the initial flow, reduced thrombosis to 2%, and reduced secondary procedures to less than 1 procedure per patient. The 4-week preparation for dialysis reduced the time to 2-needle cannulation to less than 70 days, and 87% of patients achieved this milestone. I want to thank you for your time and attention.